So we may have a bit of change from the program in the agenda, as I wish to optimize the hands-on experience. We will try to give every one of you his full time in each station of the hands-on activity. So we will start from the next session, which is the third session today, to move in a groups to the Enuclators lab. And each group will be 5 persons. Each 5 person will take almost 45 minutes to have the full activity. We will start by group A. Please be ready. And they will move with Mr. Ikrami or one of our colleagues to the Enuclator lab after this lecture. So I will announce each group. So please, group A and group B, be ready. Because we have some logistics today, we have group A, group B, and group G and group H. They will have their hands-on activity today. So we will start by group A. So please be ready. After this lecture, you start to move to have the hands-on activity, because I need to maximize the benefit, give you full time on hands-on experience. Nah? Will not have hands-on experience. Tomorrow they will have as well. So, so for the sake of time, we need to move to the next lecture by Dr. Ahmed Al-Hussein. Why prostate enucleation? Why we have to move? I'm doing very good resection. I have a bipolar machine. I can resect whatever size of the prostate. Why I have to do effort, waste time to learn a new technique of a transurethral surgery? So why prostate enucleation, Dr. Ahmed Hussein?
Assalamu alaikum, peace be upon you. Good afternoon. Why prostate enucleation? First of all, we should know what is the enucleation. I think you all know that enucleation is to anatomically dissect the prostatic adenoma off the surgical capsule, starting from the apex in a retrograde approach, followed by extraction of the adenoma or intravesical morcellation, as you see today. But which of which should we proceed with enucleation, or the resection is enough? If we go through our urology literature, we will find this unique prospective multicenter trial that evaluated the morbidity of TURB compared to the size of the prostate for over 10,000 cases. And as you can see, as the size increases, the perioperative complications increase, including the need for blood transfusion, the TUR syndrome, the need for redo operations, the UTI, and even the mortalities. So the inoculation, on the other hand, some have its advantages, including the irrigant fluid used is the normal saline. So there is no risk of TUR syndrome. That's why you can perform the bipolar transurethral resection or even inoculation of the prostate using the bipolar with no prostate size limit. It helps for good hemostasis with less blood loss, and this is reflected on shorter hospital stay and less catheterization time. But of course, the bipolar inoculation has its demerits. The functional outcomes are comparable to the standard TURP, but we may find some drawbacks, like the steep learning curve, the long duration of the surgery for large-sized prostates, and of course the initial cost. Some of you may say, I have the bipolar, I will resect even for hours. It's easy to say, it is not that simple, just like it is not that simple to kill the Batman. In our center, we performed this prestigious randomized control trial where we compared the bipolar resection versus the HOLIP versus the green light laser vapo-inoculation of the prostate with follow-up over 3 years. Our patients were randomized into 3 groups: the green laser photoselective vapo-inoculation, the holmium laser inoculation, and the TURIS. And we hypothesized that the green laser and TURIS are non-inferior to HOLIP as regards reduction of the LUTS secondary to PPH with equivalent retreatment rates at 3 years. And if we see what we found in our study, the operative time for the green light laser versus HOLIP and TURIS showed longer operative time in the green light group with less operative efficiency. The perioperative complications were more with the resection, with the bipolar resection, especially the capsular violation, the blood, the hemoglobin drop that required more blood transfusion and thus longer hospital stay and longer catheterization duration. And we came to this conclusion: the perioperative outcomes of the green laser and HOLIP surpassed that of the TURIS, but more operative time with the green light laser. But the three techniques showed good functional outcomes at 3 years. However, the 3-year retreatment rates following the HOLIP was much less compared to the TURIS and the green laser. So what is the optimum transurethral prostate surgery? How to target an optimum prostate intervention? We do believe that the optimum prostate intervention must achieve a pentafecta: the efficacy, the safety, the durability, the cost efficiency, and of course an accepted learning curve. And if we go through our urology literature, we will find dozens of high-quality publications that now can consider the anatomical endoscopic inoculation of the prostate as a new gold standard. This anatomical endoscopic inoculation can be performed with different energy sources. You can use the bipolar, you can use the laser with its different types, the green light laser, the thorium, the holmium, the diode laser, or even the new thorium fiber laser. And if we put the holmium laser inoculation of the prostate into test to check if this method of prostatectomy can achieve the pentafecta we desire. For the efficacy, there is clinical, laboratory, endoscopic, and radiological evidence that HOLIP achieves the efficacy. The infravesical deobstruction after HOLIP is proven to be superior or at least equivalent to the standard TURP, and also to the open prostatectomy for the large size prostates. And moreover, HOLIP is a very good option for recurrent or residual adenomas. And laboratory evidence that the average percent reduction of the BSA after HOLIP is about 87%. And for the cystoscopic evidence, if you can see here, I hope it works. Bismillah, yes. This is the wide prostatic fossa. You saw it today after our cases, and you see it now in this video. The resection, the standard resection, will never get you such wide prostatic cavity. And if we perform the MRI, you will find the wide prostatic fossa and the relief of the obstruction evident by MRI, proving the efficacy of such modality. For the second item in the pentafecta is the safety. The HOLIP is proven to be safe with no size limits, no risk of TR syndrome since you are using the nearly isotonic irrigant fluid. It's also safe in patients who are ongoing blood thinners. And for the sexuality, there is no negative impact on the erectile function, but of course the incidence of new onset retrograde ejaculation is quite high, reaching up to 77.3% of cases. For the durability, the reoperation rates after holmium laser are quite very low. In urology literature, the HOLIP has 95 reoperation free probability at 10 years. And for the cost efficiency, the HOLIP is proven to be cost effective in both developed and developing countries. Even after estimation of the direct costs and indirect costs, it will be proven to be cost effective. Maybe the initial purchase is quite expensive, but with the rate of cases you will use the holmium laser with, whether for soft tissues like the prostate or for the stones, and the much less comorbidities or perioperative complications, this is quite cost effective. And for the learning curve, we can ask ourselves, does learning of the anatomical endoscopic inoculation differ according to the energy used? We can check this unique systematic review on the endoscopic inoculation of the prostate learning curve. And the answer is no. If you can notice, the learning curve for both the holmium laser inoculation and the bipolar inoculation is nearly the same, reaching maximum 60 cases for the HOLIP and reaching 50 cases for the bipolar to reach a plateau. But this is not applicable for the green light laser. In literature, there is a heterogeneity of data. Some authors reported that 20 cases are enough, while others reported 200 cases are needed to reach the plateau with the green laser. So for more in-depth evaluation of the learning curve with the HOLIP, we performed this study back in 2017. to assess the learning curve for whole laser enucleation of the prostate. And we found that for adequate and accepted learning for HOLIP, you need a dense case volume with 1-by-1 surgeon training. This can optimize the outcome, and of course the hospital case volume can define the number of surgeons starting the training. And for the case difficulty, of course, the assessment of your case is mandatory. We recommend, as you start your practice with the HOLIP, to start with a moderate sized prostate of an index patient who suffers no comorbid conditions. A moderate sized prostate is a very good option to start with. So HOLIP can achieve the pentafecta, the safety, the efficacy, the durability, the cost effectiveness, and of course the accepted learning curve. You must know that the life goes on. At one time we had such type of phone, the Nokia mobile phone, and now we have the iPhone. This is how the life goes on. One day we have the classic resection that's considered the gold standard for management of the prostate, but now we have the different enucleation techniques, which can be considered now to be the new gold standard for transurethral management of PPH. Thank you so much. Yes. We still have some fibers remaining. We use it solely, to be honest, for those who have bleeding tendencies.